Welcome, everyone. This is our session 6 of our Quality Cafe. Today, we're talking about using technology for pressure injury prevention, and we have a guest speaker, Dr. Holly Kirkland-Kine, with us today. And I'm excited to see all the names of everyone that has joined. If you could rename yourself with your facility in there so we know where you're coming from, that would be awesome.
Kristen, do you froze. Let's see. I have the slides I can share, but let me grab them on here. Sorry about that. Have them open. Let me see. Let's see, slideshow from beginning. And just 1 second. Okay, here we go. I'm going to share them. Oh, I see what happened. I couldn't share right away because she was sharing. Yes, I'm going to stop that and share. Okay, can you see, Holly? You see the slides? Okay.
Yes.
Okay, so I am going to go over this. So each Quality Cafe is 20 to 3 minutes long, open to anyone interested in the topic. The goal is to foster networking and sharing. And we're currently meeting every 2 months. And here's just all of our previous sessions that we had on Quality Cafe. And we're going to have a page on our website we're redoing our website for quality leaders and for quality interests, and we'll have all the recordings up on there. So here is a slide of the pressure injury incidence. For our HQuick hospitals with greater than 25 beds, our rate of pressure injury stage 3 and above was 1.21. For 2023, 4 facilities reported 0 incidents of pressure injuries in their admitted patients. Alaska hospitals are showing an upward trend in the incidence of stage 3 pressure injuries. In addition, Alaska nursing homes have a higher than the national average rate of pressure injury prevalence in high-risk residents. Alaska has 9.1%, national's 8.9% care compare data. And so I'm going to introduce Dr. Kirkland-Kine, who is a nurse practitioner and currently works at UC Davis as the director of wound care and has led interdisciplinary team initiatives throughout the hospital to improve the safety and quality care for patients. So thanks so much for coming on, Holly.
Yes, thank you. So what I wanted to talk about today is there's so much out there now as far as AI, and the whole world is interested to see what AI has. And I think there's a way for us to make it easier to communicate with each other and make it easier to identify present on admission. And then my big goal is to see if there's a way to replace the Braden with AI, to have AI be able to predict the people who are going to develop pressure injuries and to not depend on nurses who are, they do the Braden once a shift, in some cases less than that. And usually the Braden does not change until they find a wound. And so why put the onus on the nurses? Will cut time, it'll be more accurate, it'll be more valid, and it will be more reliable. So that's my big goal. And I've included at the end of this, there's a questionnaire about, would nurses accept it? What do you think about the acceptability of the use of AI in identifying patients that would develop pressure injuries? So who should be interested in this? Well, nurses, of course, because when a pressure injury occurs, who gets blamed? The nurse. They don't ever blame the physicians. They don't blame the discharge planners or anyone else. So it's really important that we know what's happening with the patient, who's at risk. We do those things, and then that are interventions that we can do, but the things that we're not in charge of, like their blood pressure, that we can make sure that we identify that those are still playing a part. Okay, next slide. So here's one of the things that we started off with at UCD was that we had a lot of people coming in. We didn't realize it, but we are a 650 bed level 1 trauma center, and that we would have 40 patients any given day in the hospital who had pressure injuries. And so these people were all coming in with them. Our percentage was less than 1% in hospital-acquired pressure injuries. However, many people were coming in with a deep tissue injury. No one picked it up on admission, and that evolved to an open stage 3 or 4, and then the nurse was blamed. So our big push was to have this early identification. Does this patient have a pressure injury present on admission? You check the box, and then you stage it. And if you need help staging, there was a thing there that says, like, what's it say? Wound, pressure, ulcer stages. And so there's photos of the wounds on different skin tones, so you can try and decide what it looks like. But I can tell you, it is very difficult to identify a deep tissue injury, a deep tissue pressure injury on darker skin tones. Next. So here's one of the things that we found. I thought that patients who were being admitted to the hospital with pressure injuries were coming from nursing homes. I was wrong. 77% of our patients who were coming in with pressure injuries were developing them at home. And why is that? Well, if you're over 65 and you get into a nursing home, you have 24/7 care. If you're at home and you're 22 years old and you have a spinal cord injury, all you have is your mother or a family member or someone else to try and help you. And in those instances, we found we had an awful lot. So you can see the people who were coming from home. These are 336 people came from home with pressure injuries. And you can see they're pretty high level of pressure injuries too. And most of them were paras and quads, younger people coming from home. And yet when people were coming from skilled nursing facilities, they were mostly neuro. So dementia, patients who were, as you can see, into life as well. So we went through all of these to see what was going on and why these people were coming in so often, because we found they were coming in often as well. And younger age groups within the home group than within the SNF group, and far more visits from the home group, and stayed longer. Next slide. So this was something we found out. We did a research study to find out the things that contributed to hospital-acquired pressure injuries. And hospital-acquired pressure injuries happened more often in patients who had a blood pressure below 100/55. And even if it was just intermittent, maybe they just had it for 20 minutes, that would contribute to developing a deep tissue injury. Hematocrit below 30 or hemoglobin below 10. Any kind of shock that would happen, neurogenic, cardiogenic, dialysis or end organ damage. So again, when people blow up with a lot of fluid, it stretches their skin so much, it makes it really easy for that skin to break down. Projected multiple surgery. So if you came in with trauma and we did a huge clean out today, we're taking you back to the surgery tomorrow, and stage surgeries. We had a lot of people who had cardiac surgery, and they'd have stage 1, and then 2 days later they'd be back in for 12 hours. Those people were more likely to develop it. And the last 2 we put on there were because those were people who came from home, who probably had stage 4 in the past, and it closes over and it's all scar tissue. And when that scar tissue opens, it breaks open it straight down to the bone again. And so we put those in there mostly for people to be able to identify that present on admission and make sure that you do photos so people know that the scar tissue is still a stage 4. Next slide. So some of the implementation plans we did was we wanted to be able to measure the outcomes of present on admission and validate those outcomes. And so the way we did that was the nurses would take a photo, it would go into the chart, and they would then stage it. I created reports that would come to me every day, and I could say, oh, this nurse called this a stage 2. That's actually not even a pressure ulcer. And so, being able to check and validate what we're seeing all the time. Patients identified as at risk of developing a pressure injury. Again, we want to set up an AI based on those previous variables that I just listed that would let the nurse know that this patient's at high risk. And it would be like a sepsis alert and say, wow, they have low blood pressure, they're on pressors, they have this, that, all of those things that would just alert us. And also be able to stage present on admission as and with validation, because you want to know what that stage is. CMS, in all of their wisdom, knew that if a patient has a stage 4 pressure ulcer on admission, they're going to need more sheets, more nursing, more turning, a specialty bed. A lot more money will be spent on that patient. And so they do reimburse more if you identify that and have it staged present on admission. When the patient is contacted post-discharge, so once we discharge a patient, so we know they're at high risk when they're in the hospital. So when we're discharging them, we need to make sure that they have all the supplies they need for home. So why are we sending people home with, no education on turning, the family members, not education on the bed and the mattresses, and dragging themselves along and causing skin problems? So again, we're really watching for readmissions, and we now have a system where we can call patients and make sure that they had everything on discharge. I have a habit of going into the patient's room when I know they're being discharged, and I clap my hands because people like to be clapped out. Good news, I have a present for you. And I give them all their supplies, because we're just going to throw it in a landfill, all their supplies that they had in the hospital for pressure ulcer prevention. Next. So again, make sure you engage the patient and the caregiver. When we take photos, I take photos on the patient's own phone, because not everyone has access to the photos, but the patient has access to their own phone. I say, okay, I'm going to take a picture of your photo. This is what it looks like. So, this is the things you need to do to keep your skin clear. And then you have patient and caregiver engagement, and also they can share it with their next level of care. Post-discharge, we like to communicate with both the patient and the caregiver and the PCP if we can. So hard to get anyone in to see a PCP within 2 months anymore. We discharge people, we know that the standard of care and that the best outcomes are if they get seen within 5 to 7 days of discharge. It's not happening here. I don't know if it's happening there, but we just don't have enough providers to see people. And usually by the time my PCPs see one of my patients, they see the wound and they're frightened, and they say, oh my God, go to the ED. I'm like, this is what it looked like. So I have to let them know not to be frightened. We use an interdisciplinary team for planning and communication. So again, we're working together, like the dietitian, with wound care, with the nurses, and mainly case management, to make sure that this person has follow-up and care. And we share resources for education on a QR code, and I think I have that next. Implementation plan, again, have a strategy, build communication with your patient and caregiver, home health nurse, PCP. So we've spent a lot of time educating home health nurses as well. And any sort of transition of care, because again, I looked at the numbers in our hospital. About 60% of our patients are using, 15% of our patients are using 80% of the resources. And that's the way it is most every place, because these patients keep coming back to the hospital. We used to call them frequent flyers. Now we call them MVPs, or multi-visit patients. And those patients are high utilizers. So we wanted to identify those as well. Have an agreed upon contact time, like I'm going to call you in 2 days and see how you're doing, make sure you got your supplies at home, and make sure you have an appointment at a wound clinic. And again, communicate with the PCP. If you have a chance to let them know what it looks like, if they don't have access to your medical records, I make sure that the patient gets a copy of their note going with a photo. Next. And so again, evaluate outcomes, mechanisms for measurement and chart audit, data mining, and follow-up phone calls by a stroke team. So if you have a stroke CNS or someone who works with your stroke patients, make sure that they know that that patient has everything going home, and that someone's calling to make sure they don't have a breakdown, and if they're incontinent, that they have those supplies as well. We have a timeline for measurement with phone calls by CNS, and we have Cypher as well. However, the Cypher program, it's automated and it calls patients. I know I'm never going to answer a phone if I get an automated phone call. So it's not real successful, but it's something that the university has decided to invest in to try and save time. But it doesn't include any wound care supplies either. So, and again, what's the return on investment? Each pressure injury, costs more than $40,000 per event, even if it's only a stage 2. It's costing more than that because of all the care that these patients need, education, and they need preventative measures. They need to make sure that it doesn't get worse, and treatment and the rest of it. And it also, it changes their quality of life and increases their number of hospital readmissions. Next slide. So again, have a sustainability plan, shared educational programs and opportunities with your CNS, your home health nurses, your outpatient clinics, and your caregivers. And the patient photos on the phone are great. And I'll often take a picture of their supplies in the hospital too. We do short videos for people too on their own phone, because we have some available on AARP, but the patient would say, my wound's not like that. We're like, well, let's videotape you looking after your own wound. So it helps to build confidence in them, and discuss future partnerships with mentoring on wound education with outpatient clinics, primary care providers, low-income clinics, NPs, PAs for follow-up of wounds. Because again, a lot of people see these wounds and they get very frightened by them. And family members do as well. But we should be educated enough so we can let them know that they do have a chance of healing. Next. And this is that QR code for AARP caregiver education. And it has everything. They're all very short, less than 5-minute videos. And we have wound care, like diabetic foot care, pressure ulcer prevention. They're all very short, geared towards caregivers, and even ones to show people how to get in and out of a wheelchair if you're getting into the car, because we found that people needed some idea of how to do these things. Next. So a summary is, to make sure that you know how to sell your program. Patients with PI frequently admitted to the hospital. When I looked at our numbers, I would say any given day, like I said, we had 40 in the hospital any given day. Of those frequent flyers, 20 of them were always mine. 70 in the hospital any day, 20 of those patients were chronic wound patients. Most of these patients are admitted from home. There's no current practice that supports reliable discharge information or planning for care, supplies, or follow-up. So when I looked at the research, there's no one out there saying, look, if a person is at high risk in the hospital, when they go home, they're going to be at really high risk as well. You need to make sure they have everything they need at home so you can prevent it. What are the best discharge practices for discharging patients who are at risk for development of a pressure injury, or those who have a PI? We need to know. Evidence-based practice recommendations just say educate patients, educate the caregivers, home health nurses, and have a team on risk for risk and skin evaluation, and arrange for early follow-up so they don't feel abandoned. And that's often what causes court cases. People go home with this thing. They don't remember how sick they were, and they get home and they like, I got this. It's going to take a year to heal, and they feel abandoned. Outcomes to be measured: do the hospital readmissions of discharge of patients at risk for PI. Again, if we had this whole AI, it would be able to let us know who's at risk. And my aha moment was, again, partnering with caregivers, home health, and team is a real key. Next. And here's some of my references. And I can take some questions now. The card that I showed earlier with the risk factors that we found was a retrospective study that we did, IRB approved, and we looked at 25 variables of the patients who continued to develop pressure injuries despite having the best surface, the best everything. And that's what we found: long OR procedures or repeated OR procedures, dialysis, end organ damage, and again, low hemoglobin and low perfusion. So we looked at that same data over 10 years, and we followed it, and it's held true. It's all of those things that we found. And it has nothing to do with the nurse not turning the patient, has nothing to do with what kind of surface. Those are the things we can control, but there are certain things we can't control, and these people will continue to get pressure injuries. And you'll even in nursing homes, you'll often find a person has an episode of a UTI and ends up septic, goes into the hospital for 2 days, they come back out, they have a deep tissue injury, and then a stage 3 or 4. So, any questions?
There was one in the chat, Holly. It says, how did you determine which criteria to screen for identifying patient risk and admit diagnosis?
That was an iterative process that we did. And they did, we had 25 variables. And again, we were looking at albumin, we were looking at blood pressures, we were looking at weight, we looked at age, gender. I mean, we looked at 25 different variables, and it was kind of iterative because as we collected data for, I want to say 6 months over the past 6 years, we looked at the data, and a nurse called and go, you know what? I think these patients on dialysis are getting a lot of these. We're like, oh, okay, now let's look at that. And then we started to look at other things. And I said to the nurse, who's an ICU nurse, I said, why do you think these people on dialysis keep getting these? And he said, well, they already have low perfusion. And what we do is we put a line into their arm, and we tell them to lie really still. We take half their blood out of their body, put it in a machine, and we tell them to lie really still for 3 hours. So of course they're going to get something. I'm like, God, you got that right. So again, a lot of it has to do with our treatments, like the pressors and the things that we have to do to keep them alive and to perfuse their brain. Because there was a time that we did not dialyze people who had a mean arterial pressure of below 60. But now everyone gets it. And if you want dialysis, yeah, you can get it. So again, what happens is you're going to lose perfusion to other parts of your body.
Do you have like a dedicated team who just does like your data analysis? Do you use like one standardized tool, or do you use multiple tools, or is it primarily your chart review process?
It's I'm the person. So I just usually I work with the team and find out what they think is important, and should we look at this? And it's been pretty good that I was able to change some of the way that we looked at data, and the doctors were great when I said, hey, we build this in to the program, because there was another part that I did want to build in. There was there's one thing, I don't know who uses Epic, but there was a click box that you could click in Epic, and it would tell Epic to collect the very last wound note that the wound nurse did. It would collect that and send it home with the patient. I took that through the doctor's process, through IT, through everyone. And then one person said, I don't like it. It's confusing. It'll confuse the patients. We can't give them too much information. And we weren't able to do that. And so again, sometimes you could do everything right, and one person says, I don't think that's a good idea. And you're just up against a wall. So it's important to be able to work with your teams to show them that there's issues around people developing pressure injuries at home and keep coming back, or people who develop them in hospital and we haven't really educated them well enough.
Yeah,
oh, sorry.
Go ahead.
I say we have a lot of studies always going on. So.
And I know you'd mentioned AI at the beginning, kind of looking at AI as far as like replacing it with the Braden score. Do you have any automated processes that you use to track and trend your data over a long period of time, like that you are putting data into? Is it Microsoft? Like, are you using like Excel spreadsheets to kind of conceptualize your data points, or how, like when you're looking at data metrics over 5 years to kind of track and trend how your facility is doing? Do you have any type of automated processes that you started using that you found to be successful?
Yeah, just the reports that we have them send us through Vizient. They'll send reports every morning. It'll say who said someone had a pressure injury, and then I can look up their photo and see what the nurse staged it as. And so it's kind of a thing where you kind of have to stay on it. But when we were looking at the ones that developed that we had to report to the state and the rest of it, we put them all on an Excel spreadsheet. There weren't that many. We'd have about 12 or 18. We had an awful lot during COVID, and we actually did a study. We just published that last year on COVID lesions versus pressure ulcers in pressure injuries in the first year of COVID. Because we found that the patients with COVID had developed these weird lesions and no one knew what to call them. And so they were calling them all pressure ulcers, pressure injuries, or deep tissue injuries. And they were usually like, instead of being over the sacrum, and this would have been in a person who was prone the whole time they were in, they would have like something on their buttock or maybe in their axilla. It was very weird. And so what we did was we separated those out from our pressure injury cases. However, when we looked at the outcomes, people who had COVID and developed a pressure injury, 25% of those died. And the people who had COVID who developed a vascular or this COVID lesion, 50% of them died. So it's sort of a marker. Oh, what do we use for proning our patients? We're still using the waffle mattresses. And you want to make sure that you don't have them too overfilled, but we use the waffle, and then we might use some different things underneath their face to make sure that we keep the airway open. A lot of people have a very thick neck, and you have to, put special pillows around and all of that. But we found it was much easier to use the waffle overlay to turn them and keep them pressure redistributed.
Yeah, and if you have a product that you specifically have found for those, like you said, people who have like the thicker necks, kind of a larger body habitus that have been successful, I would be curious to know what product you're using to elevate the head and face so that they don't get like facial pressure injuries when they're prone.
We use a combination of the waffle seat cushions, and we pat them up around their head and neck. And then we use one small Z-Flow to go around the tube. I know, nurses, we're so good at I go into people's rooms and I'll see, tape holding up the ventilator. I'm like, wow, could someone get a special arm in here? So again, we're really good about fixing things on the run. And that was kind of what we came up with. We gave a lecture about treating patients or pressure ulcer prevention during COVID. And I think it might be available on your website. That was back a couple of years ago. Mm-hmm. And it's even available on Google. So we gave that to California, 300 different hospitals. We gave it to you guys as well. And so it shows specifically how we turned people and specifically how we position them. Great questions, though.
Yeah, I'm not sure if we still have that on our website, Debbie, but I will look for that and see if I can share that. There was also a question from Jen Moore. Did that get answered? Just want to make sure.
Yeah, so I'm primarily like a researcher, but I'm also a clinician. I'm very interested in wounds. And again, I'm very interested in why for years they've been blaming nurses for these. So, people end up in a court case. I'm like, I'm your woman.
Is there any other questions for Dr. Holly? I apologize for my weird connection issues. It looks like Dina put one in. Do you have a standard tool to perform RCAs for pressure injuries?
We just use that Excel spreadsheet that we originally got, and we make sure that people are doing all the basic things like, the skin assessment. The second S is the surface is okay. K, keep repositioning. I is incontinence control, and then and the nutrition. We use that skin bundle as the interventions. We make sure that they're doing all those, and then we start looking at the individual things for patients. And again, with only 12 in a year, you can really do a deep dive, and we have a photo as well. And what we found as well is like a lot of times people want to call things pressure injuries and they're end of life wounds. I think there's a new group out called POSIC, and they're post-acute care wound care people. And they're looking at, again, getting codes for these things. So when a person develops something pretty quickly, it's an end-of-life skin failure. It's an end-of-life wound that's happening, and not to blame the nurses, but to say this is, a natural progression of death. The bundles? Oh, just that, the SKIN bundle. Is that what you're talking about? That's just the intervention bundles? Mm-hmm. Yes. Okay. Yeah. If you want to send me an email, you guys have my email there. You guys, anything that you want me to share, I'm happy to share those things.
Great. Actually, I was just about to ask that. That's okay, Holly. If anyone has more specific questions or they want to know about like the website for the waffle pillows or anything like that, is that all right if they email you?
Absolutely. Absolutely.
Okay.
And the other thing is I'd really appreciate it if people could answer the questionnaire. We're asking nurses everywhere around the world how they would feel about AI. Because again, we need to find out whether it would be acceptable. If nurses go, I don't want to have anything to do that because they're fearful or they just don't want it or they don't trust it. We want to know, is this going to be something? I'm working with the engineers at UC Santa Cruz to be able to work out this AI thing, to be able to tell us who's at risk, and it would then fire and would open up an easier way to document. Because right now I know that nurses are looking around where they're supposed to document all this stuff.
I dropped that in the chat again, so people have it.
Yeah, great. And as many as we can get. We have we had focus groups in Turkey. UCSF is trying to get people to do the questionnaire. I know no one wants to do questionnaires these days, but it would be very helpful for us, instead of asking nurses to, assess people at the beginning of their shift if they're at risk. The Braden, it's not very reliable.
Well, thank you so much,
Yeah.
Dr. Holly. And thank you everyone for joining us today for our Quality Cafe. If you have follow-up questions, you can email Dr. Holly or send them to myself or Debbie, and we can get them forwarded on. Our next session of the Quality Cafe will be in August. We're still working on our topic and our date, thinking about potentially doing something about how to read your star rating, but still working on those details. But if you have something you'd like to share, just let us know. And when you exit this Zoom, there will be a survey which will on this cafe. So it'd be helpful if you answer those three or four questions. That would be very helpful for us. And we'll stay on for a few more minutes. If anyone has any other questions for Dr. Holly, I think you could stop the recording now if you want, Debbie. Thank you.